blood pressure control a priority can achieve the outcome we want to see. Whether you're in a large integrated plan like many of you, a rural independent clinic in a low resource community, or somewhere in between. So please continue to see hypertension control as a top priority. It is one of the most important things we can do to improve health in this country. And you are California, and the rest of this country relies on you to lead the way. So I will stop there. I really look forward to the discussion later today and talking more about some of the successes and some of the slippage that I mentioned and why we're seeing this and what we can do to re-energize and get us where we need to be. So thank you very much for your time.
Why it's sensational. Okay, Betsy, so it is sensational, and I think people are really getting excited about it, and so I wanted to share some of what's going on in our world. Stroke is deadly and disabling. You all know that, right? Every 4 minutes somebody is dying from a stroke. It's the leading cause of serious disability long-term in the US and the world as well. And we already know that it's preventable. You just heard. Heart attack and stroke, it's 80% preventable. That figure holds true for stroke as well. And it's using all the same interventions that you already know. Blood pressure control, diabetes control, smoking cessation. And one thing I'll add is using the right drugs at the right dose and the right time, for including statins as well as anticoagulants for atrial fibrillation. So let's not forget that. But if you fail, then we have to remember that stroke is treatable, that we have made rapid advances in the last 3-5 years that really revolutionize care for our patients. And so that if they do break through and have an event, that we still need to get them to the care that is available for them. But it will only work if each one of you have empowered your patients or empowered yourselves and empowered your healthcare system to use what is available. So it will only work if you are prepared. So how do we do that? Think about this patient. Let's say you're in your office, you get a phone call at 8 a.m. today. You know, there's a 65-year-old woman, their partner is calling saying, hey, this patient isn't quite talking, my partner, she just wasn't quite talking right. She's substituting words. She understands me, but something is not correct. And it probably started last night at 8 p.m., but she tried to sleep it off, and it's just not better. Is this patient, oh, sorry, I'm gonna add, she just had hip surgery, and she really doesn't want to come in the hospital or into the clinic or wherever you might advise her to go, unless there's something she can do. Is she eligible for treatment? Some of you might be trying to calculate time-lapse normal, and okay, what time is it now? What time was it then? 12 hours? Oh, I don't know. Hip surgery, is that a problem? Let that go. There's so much that's changed, and we need to break away. Time is important, but not to get the patient into the healthcare system that can help them. So, step one to getting the patient the care they need is to eliminate your outdated thoughts about eligibility criteria for stroke care. Some of you are calculating this. IV thrombolysis between 0 and 4.5 hours, thrombectomy, mechanical thrombectomy between 0 and 6 hours. That's old, it's of the past, and it's changing rapidly. So get on board, right? And how is that possible? How does this work? How do any stroke treatments work? And this is critical to understand as we're going to see the coming changes in acute stroke care over the next years, and decade. And it all goes down to this. When you're having a stroke, there's a blood clot, let's say, that lodges, in this example, in a large blood vessel in the brain. Some of the area might be dying. That's what we call the ischemic core, or dead tissue in the brain. We actually can't get that back with stroke therapy. What we're all trying to do is save the larger area of brain tissue that's at risk, that's not getting enough blood flow, oxygen, nutrients, but is not yet dead. It's reversible. This is what we're trying to save. And that area, that mismatched area, we call the penumbra. So here's a more schematic version, that there's some ischemic core, the already dead tissue, and then there's the larger yellow area of penumbra, which is the part we're going to save. And so if there's a mismatch, that's an opportunity for treatment. And you're going to hear a little bit more about why that mismatch can exist hours and maybe days after a patient has symptom onset. Contrast that with this person who might have, within minutes or hours, already killed most of the brain tissue in their brain, and that there really isn't any more area mismatch or no penumbra to save. And that patient is not going to be eligible for therapy. So how do you know? How can you measure what a mismatch is and get the right patients the right care at the right time? Well, technology. I'm from Silicon Valley, UVP. We use technology, okay? So technology, we talked about how we know the treatments that are out there and we can use them for prevention, but technology can help us be precise to identify the individuals that can benefit from advances. And that's where multimodal imaging, like CT perfusion or MR perfusion, come in. And if you work with a large healthcare system and you don't have perfusion imaging, you have a problem. And that's because if you have a large vessel occlusion, a blocked blood vessel in a large territory that's at risk for a severe stroke, a severe disabling stroke, then you need to get this measurement, where this program can tell you the pink is the core or the dead tissue, and the green is that penumbra, that large area at risk that you can still save. Like in the case of this person who called your office, who's having aphasia, a focal neurological symptom in the left MCA territory, but has not yet stroked out that area. This is an opportunity for treatment. And in this particular case, the patient did undergo a mechanical thrombectomy, and the next day a head CT showed that the area that was predicted to die was in fact, that small area was permanently damaged. But all this area that was causing the symptoms, that's clean. The patient didn't have stroke there. You just reversed stroke. You can do that. And how do we do this? So mechanical thrombectomy is the most common technology that we use. Some of you may have already seen this, but basically, actually, I wonder if this will work. Yeah. So basically, a catheter is going up a large blood vessel through the blood clot that's lodged there, and then the stent retriever device, which is one of the examples, most commonly used devices, kind of gets released, gets the blood clot, and then you can pull it back out and remove it. So we have reliable technology that removes these blood clots. And then the next question is, do we have a way to show that that causes an improvement in function, that it slashes disability, that we're not just taking blood clots out with a technology, a device, but we're actually proving functional benefit, because that's what really matters. And so if you've ever read a stroke paper, you'll have read something about disability, most likely the Modified Rankin Scale, or MRS. This is a scale that measures disability and death on a scale from 0 to 6. 0 is after the stroke, the patient had no symptoms remaining, and it was like they were back to normal. And 6 is dead. We consider a good functional outcome in a patient who's undergoing thrombectomy because they had a large vessel occlusion or LVO, something between 0 and 2, where 2 is the patient is walking, they're independent, they can look after their own affairs, but maybe they've lost the ability to do something they did well before, like text, but it's not critical to their life function. A bad outcome is 5 to 6. 5 being bedridden, institutionalized, having 24/7 care, and 6 being dead. 5 is sometimes considered worse than 6. And believe me, that's happening if we don't make a change. So, do endovascular therapies provide a benefit in functional outcome and improve independence? Yes. In 2015, several newer trials were done that had shown that if you take patients that present with a large vessel occlusion within 6 hours, regardless of what their penumbra is, that the patients do remarkably better on their outcomes at 90 days compared to, in the majority of cases, IVTPA, if they were able to receive it, or those that weren't able to receive it against placebo. And so there were all these trials, Mr. Clean, Revascat, Escape, Swift Prime, Extend IA. And what you'll notice is that the blue bar is how many patients had a good outcome at 90 days, so that's what you want, and that the yellow is the control group. So the bigger the difference, the better the improvement. And actually, if you start to look at these guys that really had a bigger bang for their buck, what were they doing differently? They were using that rapid technology, the automated perfusion software, to select patients, as opposed to these trials that just took anyone who was within the time window. Precision medicine works. Finding the patients that have tissue to save is going to get you a better outcome. And this revolutionized care and really got guidelines to change. And we pushed even further. If this philosophy is true, then why wait for 6 hours? Why not go further? Why not go to 24 hours to start? And that's exactly what we did. So at Stanford, we ran the Diffuse 3 trial looking at patients with large vessel occlusions who had a mismatch and presented within the 6 to 16-hour time window, where the median patients were arriving within 11 hours of their symptom onset. And in Dawn, which was a similar trial done, sponsored by industry, they went out to 24 hours with a little bit different patient selection criteria, but always using that automated, rapid software to determine who had a right mismatch that would be eligible for treatment. And this changed history in stroke. For the first time in acute stroke treatment trials, there was the largest gain in functional independence found, with the Dawn results showing a 35% increase in patients who fall in that good functional outcome of independence, MRS 0 to 2. And Diffuse 3 showed similar results, as well as the largest reduction, 20%, in death and severe disability. So here's the data. There are these shift analyses where you can see patients that got the intervention, okay, in either study, and how many were in the 0, 1, 2, and so on death group. And you can already see in this shift analysis that compared to the control, there were fewer in this dark, deadly category, and way more patients that were having independence. So Hattie asked me to say, how do we slash stroke, death, and disability? This is how. If you've missed the boat on prevention, find the right patients and get them to treatment. It works. So the AHA guidelines in 2018 and the most recent ones that just were released, a couple weeks ago, both recommend at level 1A extended window thrombectomy for patients who present with a large vessel occlusion and meet some kind of perfusion mismatch eligibility criteria within 6 to 16 hours, because those were 2 trials. And then remember, one of the trials was also included patients up to 24 hours, so that's recommended at level 2A. And this is what we do. So you need to figure out how to get your patient to a place that can do this if they qualify. Some of you might be asking, well, what about IVTPA or the thrombolytics? What about medications? Shouldn't this philosophy be the same? You're right. We need to find out. Last year, the Wake Up Stroke trial showed that when you take patients that were over 4.5 hours out from their stroke, so outside the traditional IVTPA window, and they had a mismatch on their imaging using a different technique with MRI, that those patients did have an improved functional outcome with an absolute risk reduction of 11.5%. There was a similar trial in 4.5 to about 9 hours out going on in Australia called Extend. They actually had to stop enrolling because their investigators lost equipoise after they saw the wake-up results, but they had enough data to again show a positive benefit. Another trial looking at the same thing didn't enroll as well, and so it ended early and didn't have a positive result. And so I think the jury's still out there a little bit about IV thrombolytics. The new wave is actually using IV tenecteplase, which is a similar thrombolytic but only requires 1-shot dose and no ongoing 1-hour-long bolus. and is much more, it has many more purported benefits. And that using patient selection with perfusion imaging, we might be able to extend the window to maybe 24 hours, as in the timeless trial that we're enrolling in at Stanford, or 12 hours in Tempo 2, or this one, Twist, is using a different type of imaging criteria. So look out, because this is all happening, and in fact, in the recent AHA guidelines for acute stroke that were just released, the results from Wake Up were captured here as a level 2A recommendation that if a patient does present with that MRI mismatch that they used, that you may even consider giving TPA within the after 4.5 hours. Has anyone done that yet? I haven't either, so stay tuned. But it's pretty exciting stuff. And so if you know all this, then how do you get that patient that call on the phone to access this and slash disability? You have to empower everyone you come across with. You already know who's at risk for stroke. So many patients, what is it, 25% of patients who have a stroke have had a stroke before. You already know your hypertensives, your diabetics, and your smokers. You need to recognize what those symptoms of stroke are and empower the patient to know to call 911 to enter the acute system of care that can provide them with this technology. Because if any of you were listening to that case earlier and saying, maybe I better have them come into my office and figure out what's going on, forget it. If you thought stroke was in the differential diagnosis, you tell that patient or you call 911 for that patient. Because we have care, and even though we have more time, it's not that we have more time to think about whether this patient is eligible, we just have more patients that are eligible. And that's really important, because I don't want you to walk away from this thinking that, oh, now I have more time to figure out who can get the care. That's not true. So if you think about those early trials that I showed you, the Swift Prime, Revascat, the ones that went up to 6 hours, those patients had a benefit, right? Remember, blue is with the therapy, yellow is with the control, and this is the difference of how many patients had a good functional outcome. What was interesting is that when you took the later window patients, remember these patients had a median entry of 11 to 12 and a half hours, they did even better than the patients that presented at 6 hours. So again, I don't want you thinking, later is better somehow. In fact, what they were doing is they were capturing patients who were sparing that death of their tissue, who had better collaterals, who have a better ability to protect themselves against the stroke effects. And so this is a little bit complicated, but really important to understand, is that individual patients have different rates of ischemic cord growth. My boss, Dr. Albers, who organized the whole study, calls it the late window paradox. And what that means is that as time goes on from your symptom onset, you don't know if you're going to be in the, I would say, 20% of individuals that very quickly get a large volume stroke early on, whether you're going to be in the 20% group that kills more of your brain cells, but at a moderate rate, maybe like 10 to 15 cc's per hour, or if you're going to be among the 50% of patients in Diffuse 3 study that when they were imaged at around 10 hours, had only had maybe 10 cc volume of the actual ischemic irreversible stroke death. 50% of patients were slow growers and would have been eligible for a late window treatment. So very exciting stuff. Some of you might be asking, well, how do I figure out if I'm one of those? What's my collateral score? How can I predict in advance? And we're still working on that. We don't have the answer. So until we know ahead of time, and we don't even know if that would be the same answer today as it is tomorrow, your job is to recognize the patient early, empower the patient to come in early, call 911, get to the stroke system of care, so that you can let the technology and the systems that we already have established do their job and prevent disability and death. And so step 3 is ensuring that the system of care is ready for rapid triage and treatment of a patient who might be eligible for thrombolytics, large vessel occlusion patients that might be eligible for mechanical thrombectomy, or whatever other new technologies are on the horizon. And so at Stanford, we do this, where the stroke patient in the field, as soon as they arrive at the emergency room door, we consider them for the traditional, IV TPA decision making, and we're gonna have to modify this now. And then very rapidly get them the multimodal CT imaging with that automated perfusion software to understand. Here I wrote large vessel occlusion, but maybe I'll add extended window IVL to place here next, and determine if they're eligible for those therapies. Or we have a separate code for patients who arrive outside of the traditional time windows, and then getting them the appropriate technology to figure out if they're treatable. And we keep those standard work similar so that we get patients rapid care in the systems we know work. We use a little criteria of NIHSS less than or equal to 6 to help triage this, but each of you will design your own systems in your healthcare groups and hospitals that you might work with to make sure that your system is ready to help these patients get the care they deserve. Because I think Dr. Shortell said it, we want care that's safe, effective, timely, personalized, and we have that, but it also has to be equitable and accessible. And those graphs that Betsy showed at the northern Eureka area and that Fresno belt in the middle of California, it's not happening for them. All those patients come to Stanford, I think, and maybe some of your other centers, but we're not seeing them all. We don't have enough beds. We just opened a new hospital. It's just gonna get filled up real quick. And we need all of you to think more about how to make sure your systems are serving your members, your patients, whoever, to make sure that they can access what we have available. So I will say that that age-old mantra of time is brain has evolved, that we need to time every brain with precision regarding tissue perfusion, and that if we remember this technology, the penumbra, if we remember be fast to get patients care, and if we remember that we need to have stroke systems available that access the technology available, that we will slash stroke, disability, and death. So thank you.
Our Sacramento chairman needs no introduction, but while they get their slides ready, I'll just say that this physics undergrad is the one who really understands what I'm saying and really knows how to drive that get to zero equation. He actually has worked on the equation over the last year, and with that, I will leave it to Bill to blow your hair back.
Thank you very much for coming today. We really appreciate this attendance. Hattie asked me to say a couple of words about the UC Davis program, and we wanted to show just briefly some of the results that we had. Improving the control of blood pressure in both non-diabetic and diabetic individuals, and getting increased compliance for that, and raising from 66% up to 74 and 80% in that data. So that was an important change. And how did we do it? Well, at UC Davis, it is a team approach. And so this award is not mine. This award is the team that did this information and did this great job. And if we look at the results of improving blood pressure control at UC Davis, it was a couple of programs, the Measure Up, Pressure Down, which was a program where a nurse actually took over the blood pressure measurement, changed it, repeated it, etc. That was involving them in the team for doing that, and allowed us to not let a patient leave the clinic who had a blood pressure over 140 without doing something at that time. The second thing was the Better Blood Pressure program, which involved pharmacists and brought them in to actually manage blood pressure individually in those individuals. And that was very useful in dealing with individuals who had blood pressure that was harder to control or resistant. And the last was the rollout of Healthy Planet, which was an EPIC program using what was called Slice or Dicer. We were able to identify individuals in the clinics who had hypertension, identify them, and actually target them with appropriate care at that time, using for the first time electronic medical records to actually help us identify and treat these patients at this time. These three programs, I think, were responsible for helping to increase the compliance and the ability to get many more of our patients under control. So that was briefly the program at UC Davis. We made good progress. But the problem is, we want to make even further progress, and we want to do an even better job at this point in time. So that's where we're looking at getting to zero. We can reduce the risk. We want to go even lower than that for both blood pressure and cholesterol control, further reducing the risk of cardiovascular disease. We're going to talk about a couple of ways of doing it. First, for those with existing disease, that is secondary disease interventions or prevention. We're also going to talk about ways of getting to even lower risk, especially for primary treatment, encouraging lifestyle changes and starting early in the individuals. So first of all, for the individuals who we see with existing cardiovascular disease, we have a large state. Last year we did 64,000 coronary interventions or PCIs. We did about 14,000 coronary bypass surgeries for those individuals. We do monitor that program and look carefully at it throughout the state. It is a process where we introduce legislation, find out and collect evidence how it's doing, look at outcomes, identify outliers, work with those hospitals not doing quite as well, or programs to improve their outcome, and then look at further performance measures. It's an iterative process, so we go around this wheel multiple times, each time introducing new legislation or tweaking the legislation to improve it, to further use or generate data, and further improve outcomes in this patient population, leading to changes in guidelines that we use. This iterative process has led to a reduction in cardiovascular morbidity and mortality for interventions, that is both cardiac surgery in the state of California, where we monitor every cardiac surgery, and for PCIs, or coronary interventions, where we monitor every one of those in every hospital in the state of California. That has led to the California Elective Offsite Program, where we're now able to do it in smaller hospitals that don't have existing cardiac surgery. We're looking at aortic valve replacements with catheters now rather than surgery. And we're now introducing a bill that relates to doing this in ambulatory surgery centers without hospitals at this time. What do these do? If we do it carefully, we can get programs that are just as safe and effective as in the bigger hospitals, and importantly, we can cut the cost. We can cut the cost as much as 50% by moving in this direction. So part of our process is to not only improve safety and efficacy, but to reduce costs at the same time, because as we all know, our costs in the U.S. are extremely high for cardiovascular care. Moving on from that, we know that a coronary stent, as you all know, is very effective in an acute myocardial infarction and can save lives. But the stent only fixes 1 centimeter of the coronary artery, and you've got 30 centimeters that are there. So we're better off in most situations doing medical therapy to try to reduce plaque in the other 29 centimeters of the coronary artery. So we do focus on secondary prevention, and that secondary prevention really relates to doing two things: statin therapy, which is relatively very cost effective, and healthy lifestyle in that population. So here are the current ACC/AHA guidelines for the treatment with statins, shown in pink here. All of these areas are important for secondary prevention in clinical atherosclerotic disease. Healthy lifestyle applies to all of these patients as well at that time. And with that, we can further reduce the incidence of further complications. But we want to go one step further as well. We want to also try to prevent cardiovascular disease, and getting to zero is important. We actually created some equations related to getting to zero, and they are based on a couple of large trials. The Inner Heart trial looked at 52 countries in every ethnic group that was available. And this is the actual formula for doing that. You can see by treating or controlling cholesterol, smoking, stress, diabetes, hypertension, and abdominal obesity, you can reduce the incidence of myocardial infarction. and by increasing fruits and vegetables, physical activity, and moderate alcohol, it can further reduce events in that population. How much? It was estimated by Salim Youssef in that trial that